Good afternoon, everybody, and welcome to the webinar. Today, we are in our second of our series regarding COVID and cardiovascular disease. Today, we are talking about an increased risk of COVID to those who have cardiovascular disease. So what you need to know as a cardiovascular patient, risk factors, the danger to the heart, and all of those things. We are very lucky to have Dr. De Almeida. I just said it wrong. You just told me and I said it wrong. With us, he will be able to pronounce his name. But before we get to our fireside chat, just wanted to introduce the organization. If you are not familiar with Mended Hearts, our mission is to inspire hope and improve the quality of life for heart patients and their families through ongoing peer-to-peer support, education, and advocacy. You can find us all over the web and on all the social medias, mendedhearts.org, myheartvisit.org, and we also have a heartline that you can call to get connected with somebody to support you. Before we begin, all attendees are in listen-only mode, but if you cannot hear, hopefully you can see on my slides, and you can check the audio button on your personal computer to assure the sound is on. Please type your questions into the Q&A box at any time during the presentation. We will be reading and answering the questions throughout the presentation. Just note that the presenter will not be able to answer specific questions about your child or you as a patient, as he is not your treating physician. We don't have slides today because we're going to do a fireside chat style, but the recording of the presentation will be available after the end of the webinar. So now I would like to introduce to you Dr. De Almeida. He is an internal medicine, infectious diseases, and travel medicine. He's affiliated faculty of medicine, University of Miami, Miller School of Medicine, and at JFK Medical Center in Palm Beach County, Florida. So I really appreciate you taking the time to be with us. I'm going to stop sharing my slides so that we can see you. And let's get started. So thank you for joining us today.
Oh, it's my pleasure. It's second time that I do one of these programs with Mended Hearts, and it's wonderful to be able to connect with patients, with the institution itself, and answer their questions and calm their fears, or inform.
Yeah, so COVID has really been obviously the talk of everybody's life for the last almost 2 years now. And sometimes heart patients hear conflicting stories. And so today we would just like to kind of get to the bottom of what our risk as a heart patient is and how we can kind of navigate this COVID and cardiovascular disease like pandemic going on. So let's start with just the risks of being a heart patient and in the world of COVID.
So the risks are mildly elevated, as they are for anybody who has a chronic condition. So one of the risk factors for COVID is age. So the older one is, the higher the chance of having a severe case of COVID. But the other part of it is the more comorbidities, the more other medical problems someone has, the greater their chance of having a more severe clinical case of COVID. And that's where being a heart patient comes into play. A lot of heart patients have some other medical problems, usually kidney disease, diabetes, etc. And when we add obesity sometimes, and when we add all of these risk factors, it puts people at an increased risk of having complications.
Got you. So what's the risk of you becoming a heart patient after you've had COVID? Are we seeing any of that now?
That risk is minimal, is really infinitesimal. The significant complications with COVID have really to do with myocarditis, pericarditis, And those are the ways. This is someone who just sent me a message about their child with COVID. So it's still out there. And earlier today, I was listening to a radio program, and they were interviewing the person for the CDC, the chair of the CDC. And she says, we're now reaching our lower steady state, but that means that we still have between 60 and 70,000 new infections per day of COVID and about 1,000 deaths per day in the United States. So that parenthesis aside, coming back to the question, it's, and reformulate the question for me again.
So I guess if you're not a heart patient,
right,
and you get COVID, are we seeing long-lasting damaging effects to the heart?
Right. I got it back. So no. So the cases of myocarditis that we have seen have all been transient, and the case and that is a concern not only with COVID but also with COVID vaccination. But what we are seeing is that the risk of having one of those complications after a natural infection is higher than having that complication from vaccination, number one. But those two risks are so low that the quantification of those risks is less than one case in several 100,000 cases of COVID. And in both cases, vaccination related or natural infection related, the period of heart dysfunction has been limited. So it's not something that has been described as leading to permanent cardiac complications.
Great. So that's reassuring to hear. So as we'll talk about vaccines in a little bit, because I know that that's also something really important that people are talking about. But what does winter look like, do you think, in terms of the outbreak? Are you hearing things from the experts as in turn of what this winter is going to look like?
We are cautiously optimistic because of this decrease in our sheer number of new cases in the United States. When we talk about the entire country, some areas of the country are doing much better than other areas of the country. But for example, here in South Florida, we went through the Delta peak back a couple of months ago, 2 to 3 months ago, and it led to more infections and more people hospitalized than in 2020. So and that was a story that repeated itself all over the country. Now, in some of the northwestern states, Idaho, Alaska, they were overwhelmed with new cases of COVID as of a month ago. They had outstripped their supply of hospital beds. Hospital systems were having to make decisions of who to provide mechanical ventilation versus who to not provide mechanical ventilation. So the situation was very dire in those places. Fortunately, the majority of the country did not face those problems. But and the other fortunate thing is that we see, in general, the number of new cases of COVID decreasing progressively. The winter is a concern because we go back to this setting where people are in confined spaces just to protect from the weather, and also a co-circulation of other respiratory viruses. So there is influenza virus, there is respiratory syncytial virus, there is metapneumovirus. All of these viruses cause a clinical syndrome, a constellation of symptoms that is like COVID. So we are all going to be very attentive to patients presenting or developing respiratory symptoms. And every person who develops a respiratory symptom heretofore will be tested for COVID. Now, that brings me a plug for the importance of being vaccinated against these other pathogens that you can be vaccinated against. So very important, we think, this year to be vaccinated against influenza. And later on, we're going to hammer COVID vaccination to oblivion. So I'll save it for then.
Yeah, and I think that that was going to be one of the things we wanted to discuss was the flu shot. And, you know, is it still important, as important to get the flu shot? And you just answered the question as to
Yeah,
yes.
I think it's very, very important. Influenza, you know, up to the COVID, up to the onset of COVID, influenza was our most common respiratory infection. We had a very cavalier, a very relaxed attitude towards influenza. We took it as a fact of life that influenza was going to be around, and we took the influenza vaccines, which were okay. They're not as good as far as protection as the COVID vaccines. But the one thing to be said about influenza vaccines, and also it's a characteristic of the COVID vaccine, is that once you've received either influenza or COVID vaccine, it becomes extremely difficult to die from one of these conditions. So it's very protective as far as preserving life. It is the COVID vaccine is very protective as far as preventing us from getting the infection at all, a little bit better than influenza, but both of them perform in greater than 99% efficacy in protecting life. So that's a point that I'd like to share with you guys. And hopefully, if there's any doubt as to whether you should take or not take, hopefully it will be a data point that you would consider.
Yeah, I think that's great. And so in talking about vaccines, are there certain populations or people that should be wary of getting the vaccine? I assume that with heart patients, I mean, overall, we've heard that the vaccine is safe for heart patients. Is there a specific type of patient that should be more cautious?
The only people that we have identified that should be more cautious, particularly with the two, in quotes, better vaccines, the messenger RNA vaccines, Moderna and Pfizer, and there's another one that will eventually be approved called Novavax, are folks that have a history of anaphylactic reactions to vaccines. And even for those folks, as long as they come prepared, or they let the people that are giving the vaccine know, and the people that are giving the vaccine make the appropriate preparations in having an EpiPen around, etc., they have been able to take their vaccines and be protected against an infection that can be pretty serious.
Yeah. So what are we seeing in terms of breakthrough cases? I know I hear a lot of people talk about, oh, I had my vaccine and now I got COVID, so it really wasn't worth it. So can we talk about, maybe bust some myths surrounding those breakthrough cases?
They do exist. They are responsible for less than 10%. They're responsible for around 6 to 8% of the current infection. So out of those 60 to 70,000 figure that I quoted, let's say, do a very high top and say 10%, 7,000 will be breakthrough infections. The other 63,000 will be infections de novo in someone who either has had COVID before or who's getting COVID for the first time. What we know is that equal to that, or even better than that, 98 to 99% of deaths from COVID now are happening in people who have not been vaccinated. So can one who has gotten a vaccine get COVID and die from COVID? Yes, they can. But what are their chances? Their chances are extremely low. Their chances are, and we go around every so often and buy a lottery ticket, the chances are close to winning the lottery in reverse. So it's about the chances of dying from COVID once you've been vaccinated is less than 1 in 1 million in the highest risk group, and less than 1 in several million for folks that are not at high risk.
Fantastic. Thank you. There seems to be some confusion for boosters as well. Can you clarify who qualifies for a booster?
So anybody, let's go for the easy population first. Anybody over the age of 65 qualifies for a booster. Anybody who has received, and that is without any age criteria, anybody who's received the Johnson & Johnson vaccine should also have a booster, either another Johnson & Johnson shot or a Moderna or Pfizer shot. Anybody, and then the criteria were open to folks who are living in places where there's a congregation of other people. So people, folks who are living in extended care facilities or assisted living facilities, those folks, because of that community aspect and the increased risk of coming in contact with COVID, just because you're going to be commingling with that a higher number of people all the time, those folks were also offered the possibility of taking a booster shot. The other population are folks who, by their lines of work, will come in contact with COVID more frequently. So people that work in healthcare, in particular, people who work in healthcare facilities, physicians, nurses, patient care associates, folks that work in engineering, in environmental services, pharmacists, everybody who is working in a healthcare facility should consider taking COVID, just because it's an environment where there's increased amount of COVID circulating around, even though when we put together the number of people who have acquired COVID because of a hospital exposure, that number is very, very low. And why that is? It is because in most hospitals in the United States, to go into a hospital, you got to be wearing a mask. And every patient who comes into the hospital at least answers a quick questionnaire that helps estimate their risk of having been in contact with COVID over the past 2 weeks. And if they have any inkling of a respiratory symptom, they're going to have a swab test in their nasopharynx that will let us know whether they are COVID, whether they're a person of interest, a patient of interest, or someone else, or a person who does not have COVID. And they are allocated to different areas of the hospital.
Great. So do you think that, or has it been known or told if this will continue on the same path as the boost or as the regular shots were, in boosters will be for everybody eventually?
So there is we need data to show us that. The data that were used to guide the recommendations by the approval by the Food and Drug Administration and the recommendation by the Committee on Immunization Practices of the CDC was derived from a large data set from Israel and a smaller data set that was provided by the vaccine makers. The larger data set from Israel is a population-based data set in which they quantified the risk of having COVID and having hospital admissions due to COVID, and compare the population that had received a booster in Israel to the population that did not receive a booster. It was an observational study. So it was not, the quality of that information is not as pristine as when they were doing the vaccination trials, where we keep track of every single individual, but they vaccinated a bunch of people and figured out how many people were readmitted to a hospital system in Israel. And the risk reduction in those who were over the age of 60 and who had received the vaccine was up to 20 times lower than in people that had not received the vaccine. That their chances of having a hospital admission related to COVID was 20 times, 18, 19 times lower than the population that did not receive the vaccine. That benefit increased with age and decreased with age below 60. So it was a little bit higher in people that are 70, that's the 20 to 25, 70 to 80 years old. And as you go from 60 to 50, 40, 30, that benefit goes down to a couple of single digits, 3 times less likely or 5 times less likely of having a hospital admission. That is the reason why they approved specifically for folks over the age of 65.
Great. And how often do they think that people will need a booster, or is it too early to tell that?
Too early to tell, because there are a couple of things that would require a booster, right? One is waning of the immunity, so a decrease in the amount of antibodies, and followed by an increase in the risk of infection. So that's one reason. And the other reason for a booster would be, or one could argue a different vaccine, would be if another variant became dominant and one would make a vaccine against that variant. And that one could consider that a booster because it's the same virus still, kinda, or say, oh, this is a new vaccine against this variant of the COVID virus.
Okay, excellent. So one last question on that, and then I'm going to turn to a different topic. Is there still how safe is it for large events for patients with heart disease? How safe is it to gather with your families over the holidays?
With your families over the holidays, the answer is simpler than much larger events, because folks are already planning the end of the year celebrations in companies and et cetera, which are larger events, and you don't know necessarily who was and who was not vaccinated in those environments. In your family, you could gauge your risk by estimating how many of your family members were vaccinated. And if everybody had been vaccinated, then your risk is close to zero. All right. Particularly if nobody has respiratory symptoms. But the more unvaccinated people we come in contact with, the higher our risk of getting someone who's carrying the virus. So you will have to gauge based on the idea that you have of the population who are going to be surrounding you during those celebrations. If it's a family that has a lot of folks who are concerned about the vaccine and has not taken the vaccine, and if you identify as being in the high-risk group, you can go there, but you take the precautions that we have asked folks to do for the past couple of years, which is wear a mask, stay in the outside environment, so not in a closed area, not so close to each other. So that it's still for folks who are at high risk of developing severe cases of COVID, I think one needs to still be careful.
And do you think that, that I've heard a lot of people talk, well, we haven't even seen the flu in 2 years. Do you think that all of these things that we're doing to protect ourselves from COVID is helping to reduce the spread of other communicable diseases such as flu and respiratory viruses?
I think so. I think that if we continued to wear masks with the same adherence that we did when we were all very concerned about catching COVID, we would continue to find lower numbers of upper respiratory viral type infections. Now, there has been an understandable fatigue of wearing masks, even though for some folks it has become second nature. I've been seeing patients with COVID pretty much daily since March of 2020. And right now I find myself going to places and then realizing that I don't need to have a mask on. So, but I understand the people who have the opposite response that I have, which is I have not been wearing a mask, and I need to be reminded that I should be wearing a mask if I'm going into crowded spaces, crowded enclosed spaces. So I think our collective risk of coming in contact with COVID has decreased substantially when we compare with 2020. It decreased, I'd say, by more than what the percentage of folks who have been vaccinated. So we're probably 80-90% decrease in our risk of being exposed to COVID. But particularly for those at higher risk, folks who are more senior and folks who have multiple comorbidities. And if you have not yet taken your booster shot, because you are the person who would most benefit from the booster shot, that's what our data shows, I think you should be careful.
Great. So for a few minutes, I'd like to switch gears and talk a little bit about the effects or the long-term effects on the lack of care for heart patients throughout the pandemic, especially during the season that we were very locked down. A lot of hospitals and doctors' offices were not seeing heart patients for routine things. Are we seeing any effects of that lack of care for heart patients during that critical period of time?
Yeah, so we have been seeing not only with heart care, but it's our topic today, but in every other chronic disease, chronic ailment, chronic condition care. And also the other group of folks that have been adversely affected are those who were supposed to have these preventive tests, these screening tests, and that postponed the screening colonoscopy or the screening mammogram, et cetera, right? So folks have estimated that there have been a few thousand extra cases of colon cancer that were not diagnosed, or a few thousand extra cases of breast cancer that were not diagnosed as early as they could have been, because folks, understandably so, postponed their screening mammogram and their screening colonoscopy for when the situation was more, conducive to it. As far as management of chronic conditions like heart failure, like people with chronic coronary disease, the phenomenon that we have observed is that you have these competing needs. You have the increase in your symptoms, whatever they might be, versus your concern about being exposed to COVID. And a lot of people chose to protect themselves from a potential exposure to COVID. And in the meantime, during that interim, the symptoms kept on progressing, and folks have been presenting to the hospital or presenting back for care with more advanced clinical pictures, with more advanced symptoms. It doesn't mean that it's, that we don't have ways of treating you back to the place where the clinical scenario that you need to be in, to your best clinical fit. But it just takes a little bit longer most of the time to get you back to your best self.
Yeah. So we do have a lot of questions. And so I wanted to start answering some questions or reading you some questions. And in the meantime, if anybody has other questions that they would like to pose to the doctor, please let us know. The first question says, can you compare the risks for a CVD heart patient getting deep vein thrombosis, blood clots, myocarditis, or pericarditis from the vaccine versus the same from having COVID? Do the risks of those side effects from the vaccine outweigh the risk from getting them from actual COVID?
All right. On an individual analysis, the risk of having those complications is higher for natural infection than for vaccination. So if we're analyzing the data one person at a time, it's better to be vaccinated, less risk of side effects than having natural infection. Now, we have 330 million people in the United States, and about 1/10 of our population has had COVID, 1/10 to 15%.
Oh, did we? I think we might have lost you for a moment. Let's give him a second, see if he comes back. There we go.
Oh, it's telling me here that my internet connection is unstable.
That's okay. You're back. That's great.
Okay.
It's
So-
just a day in the life.
So getting back to that explanation, so the risk for the individual is less with a vaccine than with natural infection. But we've had about 10 to 15% of the population in the United States who has had COVID. But we have had another 80% of the population who has had a vaccine. So in absolute numbers, there might be more folks with the vaccines, and particularly if one took the Johnson & Johnson vaccine, if we take that population alone, there will be a greater risk in that population than if you put everybody together who had COVID. But still with the Johnson & Johnson vaccine or the AstraZeneca vaccine, which had both of them have similar risks, the risk of a deep vein thrombosis or the risk of one of these unusual cavernous sinus thrombosis or splenic thrombosis of an artery of an internal organ, etc., is lower than with natural infection.
Great. Thank you. So the next question is herd immunity still the goal? If not, what is? Endemic, if endemic, what precautions will be necessary to confine further spread?
No, I think herd immunity remains the goal. And just yesterday, we got another 26 million individuals to become eligible for vaccination. And they will get us closer to the probably 95 to 99% of folks who either have had a vaccine or who have had natural infection, to be able to, if not eradicate, which I think is going to be extremely difficult, but to have COVID be something that would be less, that would not be on the top concern if someone showed up with a respiratory infection. And eventually, I believe we're going to get to a time that if we have a significant amount of the population vaccinated, that these numbers will continue to come down, these numbers of new infections, and that we will have turned COVID from a disease with that could be deadly to a disease that is much less likely to be deadly. So I think what the real scenario is bringing down that risk of a severe outcome of death from one in the hundreds to in the low thousands, which happens in certain age groups, to one in less than 1 million people who contract the infection.
Great. And I just, on that same topic, I saw, Sam, I saw your message in chat. Since this is a global pandemic, how do we expect to reach herd immunity with all of this international travel that will eventually open up?
not only that, right? So that's the other argument that we have been considering and that you guys, I'm sure, have heard. Uh, and that's the push to send vaccines to other places of the world and get the entire population of the earth immunized. That's the only way that we could turn this infection extinct. But that is a very lofty and very difficult goal. We have one infection that we have been able to eradicate, and there was a much simpler infection than, as far as controlling it, than COVID. That infection was smallpox, and we vaccinated just about most people in the world for a decade. And the easier part of smallpox is that there were no other vectors for smallpox. And with COVID, we know that our cats and our dogs can catch COVID. We know that there are some other animals in other parts of the world that have gotten COVID. In Denmark, they had to rethink their infection control because they have an animal there that looks like a reindeer that got a bunch of COVID.
Wow.
So whenever you have an animal reservoir, it becomes very difficult to eradicate an infection. Now, the flip side of the coin is that we have a vaccine or a number of vaccines that are extremely efficacious and extremely safe. They are safer and more efficacious.
Oh, there we go again. Everybody just give him a moment. I'm sure he'll pop right back in.
Am I back?
You are back.
So I was saying that the COVID vaccines that we have available are safer and more efficacious than most vaccines that we have gotten as kids. So there we are.
Yeah. So this question is, if I've been fully vaccinated with a booster, Pfizer, should I, as a bypass survivor, avoid eating inside of restaurants?
I'll give you an answer that you're not going to like. It will depend on where you are, because and that has to do with the amount of COVID circulating in the community. If you are in a place where there is less than 5% of COVID, of people turning positive that are tested, and you can find that information in the state health department websites or county health department websites. If you are in that situation, then I think it's fine for you to go to a restaurant and have a meal. But if you are in a situation where a lot of the other citizens of that community are turning positive, and a lot, we kind of drew this line of 5% about a year ago. If more than 5% of folks are turning up positive, it suggests that there is a risk. Now, being that you are doubly or that you've been fully vaccinated with a booster, and if the only issue that you have is having gone through bypass surgery and you don't have the other complicating factors, chronic kidney disease, chronic lung disease, diabetes, obesity, other immunocompromising condition, I think it would be safe for you to go to a restaurant. So make those calculations. I'm sorry that I have to bring this all and to kind of rain on someone's parade.
We all just want to go out to eat, right? Like that's.
We do. We all want to have social contact. We are social beings, and what we have asked, folks in infectious disease and epidemiology have asked of the population to do over the past couple of years is to live a life that they had never imagined, and we had never imagined living before. And, there are consequences to those protective actions as well. And fortunately, as we get vaccinated, as our co-citizens get vaccinated, it gives us the situation where we are now, where we are much more comfortable leaving our homes without a mask, going to places without a mask, particularly open spaces, and having this conversation as to when we should go back to normal, meaning abandoning masks altogether. So we are getting closer to that. We need to convince or to give the information that will allow the unvaccinated folks make a choice. We need to, for those who have kids who have not been able to get vaccinated yet, get those kids to be vaccinated, and move the needle so much closer to being able to vaccinate every person. Also, we are expecting for the next 6 months or so data that will allow us to, or that will inform us as to whether we should be offering vaccines to our babies aged 6 months to 2 years old, so, or to 5 years old, right? So it's coming.
Great. So, and it's great that you were just talking about children, because the next question is, one of the vaccines may cause, and she said she forgot the brand, I don't think it matters to the conversation though, may cause heart issues for youth. Which is the bigger risk for kids with congenital heart disease, getting COVID and risking heart issues, or not getting getting the vaccine or not getting the vaccine?
I think that the consensus is, like other cardiac patients or patients with chronic illnesses, unless you're going to be extremely careful in protecting yourself from exposures, and that's the part that most folks are fatigued, getting the vaccine is the better option. Again, that same analogy remains, that having these complications is much less common getting the vaccine than if you were to catch the natural infection. So when you're getting the vaccine, your immune system is only being exposed to one little protein of the virus that does not have the ability to do any harm to you. So we are only dealing with our immune response to that protein, to the preparation to fight the virus if the virus were to come to our bodies. When we get natural infection, there is not only the damage that exists from our immune system fighting the virus, but there is the damage that the virus itself is able to cause to our organs.
Okay. So it says here, thank you for your very important information. What can we do with our diets and supplementation of vitamins or minerals that will enhance our immunity against COVID?
That is an interesting question, because we have had a good number of studies that have looked at a few things. They have looked at vitamin D supplementation. They have looked at vitamin C and zinc supplementation in different scenarios, in people that were mild cases of COVID, people that were at high risk of progressing to COVID, and people who were admitted to the hospital with COVID. And in none of these scenarios, having supplementation has been shown to be beneficial. The other part of that equation is that if you are following a Mediterranean diet, if you're following a cardiac diet, you are getting your necessary amounts of vitamin C, of zinc, of vitamin D, as nature intended you and I to get it. And recognize, I think it's important, every time I talk to folks about supplementation, I ask them to ponder a couple of things. One is that up to 50, 60 years ago, there was no supplementation and people lived, right? And they lived and they died. And in this period, there have been several studies and studies that have involved very large groups of people, populations of countries, in where they would send a questionnaire and ask the population, have you taken any supplements, vitamins, or haven't you taken any supplements or vitamins? And they would compare what medical conditions these folks developed and what did they die of. And they would find no difference whatsoever as to how long people lived, what did they perish from, etc. The other thing to consider is that the bar of entry for these substances into the market is much lower than the bar that any of the medications that you have taken had to clear. When a company submits an application to the FDA, they need to show a couple of things. They need to show that their product is beneficial, and they need to show how risky those products are. And it needs to show on top of that, that what you're getting is exactly what's in the label. So there are all these parameters that need to be fulfilled. When we buy supplements, supplements are regulated by the Department of Agriculture. It's like a tomato or a pear. You go there and say, this is a tomato, this is a pear, looks like a tomato, looks like a pear. You don't know what's inside. The Department of Agriculture doesn't go there and do sampling of what's inside the supplements. And it's a very large industry in our country. It's a multi-billion-dollar industry per year, the selling of nutritional supplements. Now, most folks in the United States, even if they only eat bread, they get a good amount of these supplements because most bread in the United States, unless you're only eating artisanal bread, are fortified with a bunch of vitamins. Cereal, morning cereal is fortified with a bunch of vitamins. All of these things, and even better than that, if you're following a Mediterranean diet, if you're following a plant-based diet, if your diet involves eating 1 or 2 servings of fruits and vegetables per day, you are getting these substances into your body.
Great. So the next question is, my daughter is a single ventricle patient and is 9 years post-Fontan. She is on an 81 milligram aspirin daily. Is there any indication for stopping to taking the aspirin for a certain period of time, either before or after the COVID vaccine?
No. So there was actually a very recent study that compared giving aspirin or not giving aspirin to folks with COVID, the infection. Aspirin and apixaban, which is Eliquis, for folks who were not hospitalized. And there was no benefits, and there was the risk of having aspirin. So a rare person would have a bleed, right, or any of these other anticoagulants. But as far as the vaccine, we have not noticed any increased risk of any complications, whether they be local complications from the shot, the site of the shot, or thrombotic complications or bleeding complications related to being on aspirin as you take the vaccine.
Great. So what effect will monoclonal antibody infusion have on a person with cardiac problems and positive for COVID-19?
If it is a new infection, there is a very good chance. Let me run a couple of scenarios here because the question is not so specific. So if you are a cardiac patient who has been vaccinated and you came across COVID and developed a COVID infection. Receiving a monoclonal antibody would decrease your chance of being hospitalized by about 83, 85%. So that's the benefit. Go one step beyond. If you are one of these patients who has been exposed to someone with COVID, we have data that shows that you could benefit from receiving the monoclonal antibody, even if you don't have any symptoms. We have that data from assisted living facilities and from other community settings where investigators gave the monoclonal antibodies to folks who were just exposed, and by doing that, prevented natural infection and prevented evolution of the natural infection to a severe case.
Wow.
On the flip side, what are the risks of receiving a monoclonal antibody infusion? The risks are very minimal, and they have to do with volume. You guys absolutely know a lot about swelling and dry weight and etc. So there's a
We'll give him just a minute. He'll be right back. If anybody's ever tried to use their cell phone in a hospital, that's sometimes how it has to be.
Here we go.
There you go.
So I don't know where it was left, but the risk of getting a monoclonal antibody infusion is just the volume involved in getting that infusion. And it's not a substantial volume. It's probably 300 mLs at most.
Okay, great. And so is there a lot of money and efforts being given to working on therapeutics instead of just focusing on the vaccine? Are they going in tandem? How's that coming along?
No, it's everybody wants to have a medication to treat COVID. It's a money pot that they all want to put their hands into. And Merck recently has submitted a medication for appreciation by the FDA. It's a pill that gets to be taken twice a day, and they're waiting on the decision about that, right? So, and it's taken very early in once one is diagnosed with COVID. So that's an encouraging possibility, but and a big highlight is that the efficacy of those medications don't come close to the efficacy of the vaccine. They don't come close. The vaccines are 90+% efficacious in preventing severe cases. These medications are about 60% efficacious in decreasing your chance of progressing to a severe clinical case. It doesn't mean that if you have been vaccinated and come to the hospital, we're not going to offer you either the monoclonal antibody or the therapeutics that we have. But don't forego the best measure because there is this alternative way of treating it.
Excellent. So 2 more quick questions because we're coming up on the end of our hour, which is hard to believe.
I know.
One is, can children receive the monoclonal antibodies?
No, at this time, only folks over the age of 11. So you could consider 11 to 18 children still, but it's approved for folks over the age of 11. And in those folks, only those that have comorbidity. So if you have a heart condition, you would be able to receive a monoclonal antibody. It needs to be dosed accordingly. It's dosed by weight.
Great. And then the final question we will end on is, could you clarify, you had stated 80% of people have been vaccinated. Is that 80% of the country, or was that what we heard right?
So there are these numbers vary state by state. I think the last number I came across was about 80% of folks had received at least one dose of the vaccine, and folks in the country. So we are slowly getting closer to our goal. And there are conversations going on about a pronouncement from the federal government giving guidelines to employers to mandate vaccination. So depending on your political inclination, this will be something that you will celebrate or something that you will denigrate, something that you will be upset about. But I understand that the current administration is going to continue to push for ways to get more folks vaccinated. And I guess their objective is to be able to protect the greatest amount of people and to, by doing so, get the economy back at full speed. Obviously, the folks on the other side of this question say, what about my personal responsibility, my personal liberties, etc.? And I think that, you know, those are good arguments. And other countries have found ways to deal with that by putting some criteria as to what can you do if you choose to be vaccinated and what can you do if you choose to not be vaccinated. Give some guidelines as to where people can go, what types of scenarios they can enjoy or cannot enjoy. And eventually that moves needles. You know, this is mostly done in European countries and in Israel. So
great. And then the boosters 6 months after your last date, is there a time that's too late? Like,
no,
what if you go a year? Is it there's no problem?
No, not too late. I mean, the only problem is that arguably, depending on your age, right? And let me just make a point here regarding age and need for boosters. So for all vaccines, we have noticed a phenomenon that the more senior we are, the shorter is the duration of the period of immunity. So if you are younger, you could potentially elongate that to a year. But if you are, I would say, over the age of 65, 70, which is not, you know, super, you know, old. It's not an old person. Most of my patients in my internal medicine practice are between the ages of 65 and 85. And I don't regard them as being old. They're just wiser than what we are. And because of that, most of them have been vaccinated. But on the flip side, they recognize that their immunity might be the one that lasts about 6 months. And they come and they get their vaccines at 6 months rather than expose themselves, in quotes, to another 2 months or 3 months of risk, right? It's not guaranteed infection, but increased risk of getting an infection if you're exposed to someone who's carrying the virus.
Fabulous. And on that note, we will end today. Thank you so very much for spending the hour with us. We got lots of great information and we really, truly appreciate it.
Oh, it's my pleasure. It's great to be able to interact. This format, I think it's very engaging and hopefully folks got their questions answered.
I think so. Thank you. Have a great day. And thank you everyone for joining.
Thank you. That was excellent. Thank you.
Thank you very much.
Thank you.